Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is treatment failure and switch to second-line ART in children with HIV. And the speaker is Dr. Bela Shah. Dr. Bela Shah, ma'am, is the former professor and head Department of Pediatrics and Deputy Nodal Officer of ART Center at PJ Medical College, Ahmedabad. She has been associated with NACO as a senior training faculty. She has many national and international publications to her credit and has presented in several reputed conferences. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon, everyone. I think it's been some time since I have come for the Regional Distance Learning Seminar. So quite a few and thank you, Shweta, for a very nice introduction. Quite a few of you may not know me, so it will be a nice interaction. I hope it's a bilateral learning session for all of us. I shall stop the video during the session. So, we will take the questions, Shweta, at the end of the session, if there are any, right?
Yes, ma'am.
Yes, please. So, the topic today, I'm not able to.
Oh, ma'am, click on the slide and then click next.
Yes. So the topic today is treatment failure. Now, all of us know that, in the early days, we were not talking of treatment failures because we didn't have these many children living so long and they were failing on first line. ART, in fact, has reduced the morbidity and mortality and improved the quality of life of children because we have started early interventions, test and treat policy, and a lot of things that we have come forward. And so the important goal now for all of us to see is that the ART continues virological suppression with minimal adverse reactions and optimal adherence, right? So we shall be talking about treatment response of CL-HIV. How do we identify the failure? Step up adherence and counseling, how we should go about that so that we do not have treatment failures. And if we have treatment failures, how do we counsel them for the second line and what to do in case we fail on second lines. Treatment failures. So what are we going to talk today? This is actually from the 2021 book that we have come out with NACO. And so the chapter is 3.5. So that is why that 3.5. Usually, most of the children, when we start them on the ART, are having a high viral loads. Why? Because the intrauterine and perinatal exposure to antiretroviral drugs are there. Because the mothers nowadays are on antiretrovirals and as and when they are detected. So earlier detection obviously will give a lot of intrauterine and perinatal exposures. Immature and developing immune system of the child is also to be taken into consideration. And dependency of the caregivers, because these children, as I say, are not able to decide what is good for them. They are still dependent. Over and above that, the dosing and the formulations are an issue. So, what do we mean by optimal adherence? Optimal adherence is when more than 95% adherence is there throughout the children taking antiretroviral drugs. But during this long duration of antiretroviral, despite optimal adherence, there is a chance of developing mutations, and because of that mutations that are developing, the replication of these mutations are generally very high. And there are a lot of reverse transcriptase errors that are likely to occur. So the selective pressure from the drugs or from the immune system will be there, And this will lead to treatment failure despite optimal adherence. You note that in children, the pharmacological options are limited. We are all the time talking about adherence in children, whether it's first line, second line, or third line. The reason being that we have many drugs not available, not because of non-availability of the drug, but non-availability of the formulations for children. And many of these drugs are not really tested in the way they should be, and they should be how safe they are, the safety profiles. So they are not available to us, unlike adults. And the perinatal exposure to antiretroviral drugs obviously is there, as we already know. So what happens is that to get these children to on second line is very difficult. Nowadays, at least you have a few drugs. Initially, when we were doing the first line failures, we had no drug and we were not knowing what to do. So the focus has been continuously to see that we have the best response and the sustained response to first line, so that we don't have to put these children on second line. So what is the treatment response? Could be clinical, immunological, and virological. I am going the reverse because that is how we generally pick up the treatment response. Today, we do viral loads every 6 months once we have started the children on antiretrovirals. And if we have less than 1,000 copies of the virus per ml, we say that there is viral response to the ART. So the virologically, they are responsive and they have no viral, very minimal viral loads. Sometimes they may not even have this much. So we say that the children are doing fine. Immunological response is generally seen when we do the CD4s. So if we have an increase of 50 to 100 cells within 6 to 12 months of initiation, for children more than 5 years, we say they are immunological responsive to the drugs. In younger children, it is more to do with the percentage and not absolute numbers. So the absolute numbers could be very high. Clinically, where we are very sound about is clinical assessments. And when we see children clinically every month, or initially maybe every 15 days, when we do the monitoring, we look at their weights, we look at their anthropometric evaluation, their cognitive behaviors, their neurodevelopments, we do know that they are doing well, their growth and development is fine. And we say the drug interactions are not there, they are tolerating the drugs well. We say that there is a clinical response. So, which is what we do on a regular basis. Now, most of the times, those who are on first line, we assess them clinically in the first 6 months, because viral loads happen only at the end of 6 months. And when we do not see any OIs happening, no recurrence of the old OIs if there was there, iris is not there, there is no failure to thrive. In fact, I would say when there is good weight gain, developmental regressions and delays are not there, the child is doing well, there is no decline in CD4s, then we say that they are doing fine. But in case the reverse happens and there is a treatment failure, the first thing we pick up is clinical and the CD4s. So if we see any change in the normal development, normal progression of the child, both neurologically and otherwise, we do definitely have to think about treatment failures. So treatment failure is when, if I have to define it, it would be when your antiviral drugs are not efficiently working and we need to think of a switch, right? So how do we suspect? As we already discussed, clinical and immunological indicators are first to occur, and then we will be doing the viral loads at the end of 6 months. And when you have a confirmation of unsuppressed viral loads, you say it's a treatment failure. If there is a treatment failure, then what do? We think of the next regime. Now, next regime, when we are thinking of after a failure of the first line, we say it is a second line. But before identifying just the failure based on the viral, there are lots of other things we need to be considered. Do remember that, today we decide treatment failure, tomorrow we do not start second line. Why? Because there are lots of things that need to be considered. What all need to be considered is multiple things. First, second line cannot be thought about if the child has not completed 6 months of first line. So the first thing is that the child should have at least 6 months of antiretroviral drugs. Adherence should be optimal, more than 95%. Treat and resolve all OIs. So you have to look for any opportunistic infection, because any opportunistic infection, a simple opportunistic infection in the form of a pneumonia or a diarrheal disease, will show that your CD4s could change, your development and usage, patient has some weight loss, all these things can occur. So one needs to first find out whether there is an OI in the recent opportunity and do that treatment. Once you have treated and resolved that, you need to redo the CD4s to see whether the child is really on. We can think of failures. Iris also needs to be ruled out. Malnutrition. Now, this is primary malnutrition. We're not talking of secondary malnutrition. Primary malnutrition can affect the growth and development. All of you know that, right? And primary malnutrition can affect immunity, because nutrition and immunity are hand in glove. It's like a vicious cycle that can happen. So we need to first rule out that. We also need to rule out whether there are any adverse effects which can throw the child off the balance. All these things, if we have confirmed, and then we have a confirmation from the virological criteria, then and then we say that, the child is failing. When we need to send the child to specialist consulting, either at your PCOEs or COEs or ART plus centers now, where the patient can be put on second line. Now, these are certain definitions that we need to keep in mind, because these are national guidelines. And do remember that the national guidelines are based on the fact that these have to happen across the country. And that is the reason why, we have put these guidelines here. And that is the reason why we are saying that we need to be clear and everybody needs to follow the same guidelines. So as I have said, clinical failure is when you have new or recurrent WHO stage 4 condition. Only after 6 months of ART, with progressive neurological deterioration, growth failure, developmental delays, all this will tell you that there is a clinical failure. Now, this could be different from iris. Remember, it needs to be differentiated. Your tuberculosis, uncomplicated TB, recurrent candidias, esophageal candidias may not indicate treatment failure if there is a iris, or some WHO clinical conditions like these will not be qualifying for treatment failure clinically. Now, immune failures, as we have known, are based on the CD4s. We do know that less than 35 months or less than 3 years, we have percentage, and otherwise it is after 5 years of we follow adult guidelines, but CD4 absolute numbers. And only when you have 3 criteria for more than 5 years, that is fall of CD4 to pre-therapy. So before you started antiretroviral, the CD4s are below that or 50% from the peak. So if their treatment levels have reached say 1200 and now it is not even 500, then definitely it is 50% fall. Persistent below 100 after 12 months of ART. So all these criteria, they're very well given in your charts. Please consider that these need to be picked somewhere. That immune failure is there. Then you have a virological failure where you do 2 consecutive viral loads. Understand, 2 consecutive viral loads where the viral load values are more than or equal to 1,000 copies with the following criteria. What are the following criteria? That 6 months of ART is already over. After initiation, you have 3 sessions of step-up adherence, and adherence at each of the last 3 months was more than 95. Before that, you do not do the second one. So if you have all the 3 criteria fulfilling, then you do a second consecutive one. This is just a graph that shows that why do I talk of the clinical status first, though the clinical status have failure actually clinically happens the last. Only because we are able to do the clinical detections faster. Do remember the viral failures start most earliest. Viral failures lead to their CD4s to drop, and that causes your clinical failure. So that is the sequence, how it occurs. We talked of adherence. Since now we have drugs available and we have many children living a longer lifespan, quite a long lifespan, we have started talking of failures. We have drugs for failure and we have larger number of. That is the reason why we have started putting things in place more practically, and so that everybody stands at the same and gets the same benefit. Why? Because see, we were talking of adherence, but we were really not doing adherence counseling. We did find lots of gaps because everybody responds to adherence, and our understanding and our adherence counseling was different. That is the reason why in this 2021, we have very clear-cut guidelines on step-up adherence counseling as to what we really expect and what we should do. So what do we do? Do we have as a general principle that you should have at least 3 sessions? All the counseling sessions should be taken by the same counselor, because there are some small details which could have been talked about or which could get missed. Both the caregiver and the child should be counseled together and individually. Individually, because at times the caregivers are not able to tell their issues in front of the child. And if the child is more than 5-7 years, then there are reasons that they do want to talk to you independently, because they don't want to talk about certain things in front of their caregivers. So keep that in mind. Counselors need to review all the barriers possible, including some things that are not in our hands, like finance, or it is very, very important. We all know that, right? So poor adherence and customized counseling can only go hand in hand if we know what are the barriers. And do understand that when you have an adherence plan that you are developing, keeping these 2 in mind, you should need to document this. Please document not just the weight in the white card and green book, but also what correct dose is given at the times, because that is equally important when it will come to deciding where was the barrier or where did we take this. You need to involve counselors in counseling and supporting the caregivers and children to help them achieve required adherence. But we also can have some group counseling. These are to be done when you have children with you, and especially when even before you think of, say, the step-up adherence or the failures. Group counseling can be done, and it works very well if you have an ART center where there are different age group children. They can have peers and they can talk about it. And sometimes the fears of the side effects Some children are very vocal, as I have seen in even the center that I worked in. And that child, 2 or 3 children, I remember very clearly. One of them was a girl who was very fearless. She would be very open about what are her issues. She will talk about it. She will tell others that, if you get this, this is what I did and I improved on this. So go ask your counselor or your doctor that why should I not get this help? So she was very, so in these kind of group, when you have of children, even in for say once in a month or once in 2-3 months, it helps because they do form a bond and they do discuss with their own peers more easily. Both, not just the physical, but mental health is equally important because it is very taxing, whether it is for the caregiver or the child on a long-term basis to take drugs daily, to face issues that are not generally faced by children of that age. So we do need to have that assessment of mental health and a referral for appropriate management, which is very important. So what are the 5 A's of treatment adherence? You all will wonder why we are talking just of treatment adherence and counseling, because that forms a major base for the second line to be thought about and what can we do for treatment failure. So what are the 5 A's of treatment failure? The 5 A's are assess, assist, advise, arrange, and agree. And they have to go in that manner, in the same sequence, but each has an individual role to play and is equally important. Until we assess what is the problem that is bothering that individual or the family or the caregiver, we cannot assist. And we are there to assist in addressing the barrier first. Then we can help them in planning what to do, how to do, when to do, why to do, right? Having said that, we can then advise them that regards the importance of continuous treatment, even in a situation which is not conducive for that. If required, we should be able to admit these children with the indoor facilities or do some necessary referrals that are required. So we can arrange all those things. And please remember that as we have always been talking, treatment adherence plan to address the barriers, issues of the caregivers, we do need to be empathetic and we need to agree with them as to what way forward they are thinking about. Because until we are in agreement with them, it will be we deciding what they should do and they may not understand why they should follow us. So we don't want that situation to happen. Having talked about why we need to do this, how we should do it, do remember that children are not mini adults. They are not mini adults in any form. So our counseling, when we are counseling children, should be child-centric. For that, one needs to have a rapport with the child. Until and unless the child is not comfortable with talking with you, or he does not believe that you are looking for his or her good, he will not talk to you or he will not react the way we want him to. So why? Because we want the children at some stage start taking responsibility by say 7, 8, 9, 10 years, depending on how physically and mentally developed the child is. We want them to be involved in all decisions, in the sense that if you have a child who is not doing well, and you go and talk to him that, you know what, you need to do this so that you can go, and if that child loves to go to school, then you take that aspect and you talk to them that, you know, you need to go to this School, then you need to do this. And why you should do it. What are the issues? Palatability of antiretrovirals, pill swallowing capacity, or even the pill count, keeping those charts where they can color the pictures once they have taken the drug, or if they don't like that pill, they can color it differently. So we know that these are the issues with the child when the child comes back to us. We have tried these kind of things at various different centers and it has worked. He should be counseled for everything, the benefits of antiretrovirals, how he can do his extracurricular activities. If he loves playing, how can he go and play? How can he, if he says he forgets, then you tell him how he can put some reminders for himself or herself. These drugs sometimes are not very conducive to taking good nutritive diet. And we do know that children are not really, normal children in the normal society are not really taking proper nutritive food all the time. They need to eat junk food and they like things on the streets. And we know that these things cannot be encouraged in our HIV positive children. So you encourage them and you do say, okay, once in a while, if you like this, if for an example, if you like pani puri, you know what? If you want to have pani puri, you can have it at home, or you use boiled water to make the pani and kind of things. So that is how, you are accepting their requirements. They like, say, French fries. You want them to not eat those things, but you can tell them, okay, go home and get them done. Or some such thing, or packaged food once in a while we can allow. So there are ways, because we don't want bacterial infections to occur in these children. We don't want them to get, say, waterborne infections. So we do want to keep that in mind, but we do remember that they are children still. And having said that, caregivers are also having issues. Do remember that. Why? Because earlier times, the parents were not there and others were taking care of the children. So there were other family members. Nowadays, we do have parents who are living longer life and they are able to look after their children, but they are also positive. Sometimes they have their own issues, they have their drugs that they are taking. So there are many things that are affecting their normal life. And over and above that, taking care of the child, which they want to, which they would love to, sometimes is not possible. Physically, sometimes not mentally, and sometimes not financially. So we need to, address all these issues. I feel that somewhere we need to really be empathetic to the fact that they are doing things way beyond their capacity. So, having said that, we can link them to support groups, the NGOs, welfare schemes of the government. Government has many welfare schemes, which quite a few people are not aware of. So we need to look at all those. You all also should go and look at the list of financial welfare schemes that we have for supporting them, nutritional support schemes that we have, long distance travel, we have facilities. Now, of course, the nearest facility for HIV/ART pickups are also possible. But having said that, we need to be empathetic and ensure that, there are sometimes frequency, number of pills, timing of ART also is very important. And they need to be very customized. Please remember that every child, if he is in good health, would be going to school. And the school timings may be different. Some children go and play in the evening. That timing needs to be looked at. The diet, food timings need to be looked at. The parents working need to be looked at. So there are issues that we need to understand and answer. Also, we need to be still very concerned about direct observation and adherence, so that we have almost 100% drugs being given to the ART being given to the child at the right time, at in the appropriate dose. So that is the bottom line for us. We can't not have drugs being given to them, but yes, we need to be understanding the caregiver's issues. And I have had eye-opener, if I would say that, I had a grandchild who used to come every 6 months. He would be doing fine, and at the end of 6-7 months, he will start failing, not doing well, having some issues, weight, not gaining weight, or loss of weight, diarrheal disease. Again, then he will, after 6 months, we will do all those things for him. We realized that the child was, shunting between two grandparents. These were early days, parents were not there. And the grandfather one day was very angry with our ART staff that, you want me to come on this date and I am not able to come. The reason being that at the age of 70, I have to go back to work just for this child. And when you realize these kind of things, you realize that, it's not easy. And a lot of support will need to go. Of course, nowadays we have better, the parents living a better life, so we don't have those many issues that we used to have. So, keeping all these things in mind, let us see what we would do on the first step of adherence. So, we have already had a child failing. We have decided he is failing, but we cannot, having done first viral load, now we are doing the step of adherence. So, what do? We will check the treatment from the baseline adherence, do the counseling, support, of course, the caregiver and the child so that they have the required adherence and general counseling and all that. Then, from the first counseling session, we will obviously want to also build up the rapport with the child. That is an opportunity. Explain the benefits in age appropriate, and if you have not disclosed, obviously you have to take that into mind. But one wants that to happen also. So barriers, if there are there sometimes medicines are prescribed, but reminders are not there. They are not motivated enough that 100% they need to take, and document every time all these things, including the weight. So because weight changes, the weight band changes, the dose changes. If that's not happened, the child will obviously fail. So we know that, right? We will want to assess for the OIs or co-infections, look for the mental health, if at all that is an issue, the developmental assessments, adverse effects of the drugs, and all these things as we would do for any other child. But do remember, even if the nutritional status is good, we do want him to be given nutritional counseling. So even on normal nutrition, he should take a nutritional counseling. Caregiver issues, as we have already talked, we will look at all these issues of the caregiver and also this will be our first step to be with them, understanding their problems. Having said that, we will also tell them that, look, there is some issue. Even if there is non-adherence, then because of that, or even with good adherence, we need to tell them that there is a risk of treatment failure. We don't tell them that this is treatment failure because we don't know what after step of adherence, whether the child will improve, and we will not need to switch. So we will not say that, the child has failed on first line. And motivate age appropriate disclosure, as I've already told you, and start developing an adherence plan. So you involve the child, address his issues, let him or her tell you that, these are my problems. And you start answering each of them as much as you can, helping him so that the adherence improves. When will we have a second session? A month later. And between the first and the second session, let us review what the child's adherence is, general counseling and reassessment for any new problems that have cropped up, right? Barriers, as we say, and If the child has been able to do and address his previous ish barriers and solved it, we will congratulate him and tell him that, continue doing this, and so that you have 95% adherence continuously. Is the child, encourage efforts of both the caregiver and the child, reassess the whole clinical assessment and your immune assessments if required, but otherwise his OIs, his problems that he had, whether appropriately he needs to be answered, his motivation to good drugs that he needs to take, mental health, and then he starts taking regularly. You do tell him that your reminders are working and discuss anything that needs to be the adherence to continue at 95%. So this will continue with the caregiver also, because the caregiver also will tell you what are the issues, how they have solved it, and how they are moving forward. Usually 1 month after the second session, that is when we have the third session. So you have a month's gap between the first and the second and third. Every time you have a month later, the child comes. If the adherence is more than 95% in last 3 consecutive months, that is when you start talking to the patients and the caregiver that we need to repeat the plasma viral load, and let us hope that the plasma viral load would have be less than 1,000 and you'll be doing very well for yourself. But if not, and somewhere the child has faltered on adherence, you plan a further session and involve your counselors and the support systems that the caregiver has and the child, so that the required adherence happens. Until and unless their adherence is more than 95%, starting a second line is not going to benefit. So do remember that you need to have 95% adherence at least for 3 months, and you have a very motivated child and the caregiver. And for that, so that the adherence continues to be more than 95%. You would have to re-motivate them, re-emphasize the benefits, appreciate and encourage the good effects, but see that it continues. It cannot stop, So if the adherence is improved for more than 95%, you will praise them, re-motivate them, reassess. But do remember, at this stage, we will again rule out opportunistic infections, co-infections, if at all some mental health issues that are there, nutrition if it is affected, because we will need, before we are thinking of a second viral load, discuss the risk of treatment failure due to non-adherence. Pre-existing or new adherence issues need to be answered. All 5 A's need to be reassessed before we go for the second plasma viral load. If the plasma viral load comes to less than 1,000, that means our step-up counseling was effective. And the encouragement that was provided, or the timely and proper counseling that was provided, has worked. Please also appreciate both the caregivers and the child. Advise them to continue, re-emphasize all the things that you have talked to them, and tell them that you continue on your first line and you are doing fine. But if your viral loads at the end of second step-up counseling with more than 95% adherence is more than 1,000 copies, where everything that we wanted has been done by the caregiver and the child, we still have an issue because the viral loads are not less than 1,000. That means the child is failing on first line. In that case, you need to talk to the child and the caregiver, because they need to be prepared for going to SASAP referral, for a change in the treatment regime. And all this will take its own time. Do remember that, because when you're sending a child from a remote center to a higher center, they are going to reassess and do everything again, because they want to see if we have not missed out on anything, right? So education of the caregiver, the child, importance of proper nutrition, XYZ, everything will happen. So we need to tell them that, that this is a process, and do not get disheartened, do not lose hope, continue with this, and you will be definitely benefiting from that. So as I said, if you have less than 1,000 copies, you continue what you are doing and you are fine. But if you have more than 1,000 copies, the counselor needs to provide package to the third patient for 3 months. And again, if that doesn't work, your counseling has worked, your caregivers are doing 95% adherence, but your viral loads are more than 1,000 copies. You have to have the child referred for the second line. So you need to prepare. What are the second line drugs? I'm not going into the details of the first line or the second line drugs in detail because the drug dosage and everything is available to you. But let us look at what do we mean by first line is what the initial regime that we start in a naive children as soon as you have diagnosed HIV infection. Whereas second line drug is the drugs or the regime which is used because your first line is failing, right? So as we have seen, we have to think of a second line now. The child is taking 95% adherence, but he is not doing well as much as he should, right? So what do we do? Do we start the second line as soon as he comes to the success? No. So what do? We need to look at certain things. Whether there is cross resistance. We know that AZT and D40 could have caused cross resistance. Abacavir, high levels of AZT, there is resistance, reduced susceptibility to it. All these things we know, right? There is no complete cross resistance in NNRTIs. So NNRTI exposure to children through infant ARV prophylaxis can result in archived resistant mutations. So when you have these kind of things, you have tenofovir. It will facilitate evolution of drug-resistant mutations which are resistant to non-AZT NRTIs. So NAMs could be there, your multiple nucleotide analog mutations. All these need to be kept in mind before we decide the second line. This is just when we decide what to do. So what are the steps that are followed at SASEP? As I say, SASEP will look at all the things that have been sent to them on paper. You could have sent, and they will decide, well, okay, this patient is treatment failing. So what do you do? They will decide on the NRTI component of the second line. Second, select them, decide the third component. And before you start, you will obviously want to educate and agree with the patient treatment plans and follow up monitoring with both the child and the caregiver. Having said that, please remember that in children, there is always age and weight, which are to be looked at when we decide the ARTs. The same holds true for second line. Now, for children who are, say, less than 6 years and weight is less than 20 kgs is the first column. Between 6 to 10 years and the weight between 20 to 30, that's the third column. And more than 10 years, more than 30 kg is the third thing. So what are the regimes that are available? You have ZL and lopinavir ritonavir as the first line, right? Can we change? No change in the regime. If the child has advanced disease state, then you need to send the patient to. Why? Because they need to decide shift to ALN or ALE. So that will be the second line. So if the first regime the patient is on is this, then you need to decide, because we cannot change at the peripheral center, the child will have to go. If you are taking AZT, abacavir, of course you can change to Z. But if you have lopinavir ritonavir, which was going on, then whether we need to change to Efavirenz or nevirapine we need to look at. Again, with the hemoglobins have to be taken into account because we know that AZT does cause anemias. So we need to look at all these things. The child could be on ZLE. Then, of course, you have DTG formulations in the program. If the lopinavir ritonavir cannot be given. So there are many drugs that are there, and these are the regimes that are already there on your thing. So you continue generally with an NRTI backbone, and you give the advantage of lamivudine because unless contraindicated, it works the best with least resistance. And so these are the regimes that you can shift. So if you have AZT, you will shift to abacavir. So Provident to abacavir. If you have efavirenz, you can shift to lopinavir ritonavir. If you have lopinavir ritonavir, you can shift to efavirenz. And if the child is more than 6 and 10, then you obviously have tenofovir. You already have other drug benefits, right? So you have to keep that in mind. If the child is failing, say on multiple NRTIs, then what do we do? The option of the child exposed to multiple NRTIs are limited. So it is important to assess the child in detail whether a single drug substitution is contemplated due to drug toxicities. So we have to keep that in mind. And the formulation of the second line regimen in such children will depend on the previous exposures. So do keep that in mind. Another change in such children is the non-availability of drug resistance testing, because in the program we still don't have that. If you remember, we do not have those things. So basically, in the first line for children, what we have talked about is that for children who fail on first line, do remember that if they are young, less than 6, older than 6 years and more than 20 kgs, of course, you have regimes like efavirenz based, DTG based regimes that you can use. But if you have children who are less than or more than say 10 years, then you can have tenofovir based and abacavir both as an option, as what we are talking. And third line, of course, you have your PIs. But if you in an adult, you do have other PIs also, so which you can use. There is no change in regime is recommended unless in case of advanced clinical progression, because switching to second line nevirapine based regime will be re-challenging after close hematological monitoring, and that requires continuous monitoring at the center where these facilities will be available. So this is what I wanted. These are the regimes, like as we said, tenofovir, you can go to previous exposure, have to look at the previous exposure. Currently, he was on TD. Now, previous exposure was to AZT. So what are we left with? Again, we have to go back to AZT. Previous exposure was there. But with this time, you do have DTG. So DTG can help you, and sorry, that will be the addition that you can. But do remember that whenever you are re-challenging, you have to keep AZT based NRTI in back as a backbone. Then you have to be monitoring these children very effectively. The same thing, exposures with NRTIs. So to make life simple, what I would say is keep in mind that there are limited options for second line for children less than 3 years who are receiving lopinavir ritonavir based regime. These children should be continued on the existing regime with careful monitoring and due to poor palatability of lopinavir ritonavir. And in such cases, switching to second line nevirapine based regime should be considered. However, because there could be an archived resistance to nevirapine, we have to keep that in mind then you may have to use some references with where you can use 3 NRTX, right? And for children less than 6 years and 20 kgs of weight, those who are receiving efavirenz-based first line, lopinavir can be used, and these children can be transitioned to DTG, right, when they reach 6 years and 20 kgs. So there is an option. If the children are older than 6 years, more than 20 kgs, of course, efavirenz-based regime can be shifted from lopinavir, ritonavir, you can shift to efavirenz, or from efavirenz, you can shift to lopinavir. If you have either or, dolutegravir can be used as a third drug in the second line. So just I'm simplifying the few things that are there so that, but do remember there are charts. These are your references available to you. What are the modifications if you have the option of deciding? But now if you have tuberculosis as a co-infection, what do we do? Modification of ART regime is there required because these children are receiving rifampicin-based anti-tubercular treatment. So the current second lines are DTG based because that is what we are using since 2021. Lopinavir, ritonavir based regime could also be there. Efavirenz based regime could also be there. So do remember that DTG, if is given, you will double the dose of DTG. If lopinavir ritonavir is given, you will super boost the lopinavir ritonavir with an additional ritonavir. If there is efavirenz based treatment, you will do nothing. But if you have a lopinavir ritonavir DTG treatment, you will add drugs to both. That means DTG will become double dose, lopinavir ritonavir will become super boosted. Do remember, because we do not have anything to replace rifampicin, we need to do modifications in our antiretroviral drugs. We cannot change the ATP, so we change the ART. Initiation, as we already know in the first line, initiation of second line and anti-TB treatment is the same. If child has been identified with first line failure, who is simultaneously diagnosed with TB co-infection, anti-TB treatment takes priority. Anti-retroviral regime starts within 2 months or earlier if required, right? So it is always that anti-TB treatment takes initiation priority followed by ATP. If both already on second line and he develops TB, what do? We start anti-TB treatment and modify our antiretrovirals. So that is what is already given here. I shall not be discussing this in detail. It's almost the same as what we have said. And since we know that rifampicin is not to be replaced in children for the TB treatment and is a potent inducer of drug metabolizing enzymes, so we need to change our antiretrovirals accordingly. What kind of monitoring we do for children? So what kind of monitoring are we doing? We are almost monitoring everything. And this is just lab monitoring. Please remember, whenever you have a patient on second line, your monitoring will start from your clinical assessment, your weight, your anthropometry, your neurodevelopment, to your nutrition, to everything. These drugs that we are giving them have a lot of side effects. If at all, number of drugs, pill burden, we want them to eat more than, if I'm talking of the nutrition, almost more than 50% of normal food, we want to add there. We are not able to take the normal food itself because once you have a patient failing on second line, you will be starting all other things like all prophylaxis, co-trim prophylaxis. You will want to give them, most of the times they may be deficient in your routine things. So you'll give vitamin A, vitamin D, B12. When you're doing all this, number of drugs that are ongoing are a lot. And we all know how difficult it is to give a child a drug at the same time, every day, even for 5 days of antibiotic course. Here we are talking of lifelong. Please remember that monitoring will have to happen at every level. We will need to empathize and be there with them for all their issues and help them address them. And over and above that, do their lab test. It's not easy. But yes, we need to look at their lab reports because we need to modify the drug side effects, drug interactions, any other drug that the child might require. If the child undergoes a convulsion and he needs anticonvulsants, we need to react. So there are a lot of things that go on with the second line. Do remember that all that has to be taken into consideration. Viral loads, CD4s, yes, baseline and then 6 monthly have to continue. Dreadful situation that I'm coming to is second line failures and third line ARTs. How do we go? Again, major reasons for them failing are the same as first line failure, right? So poor adherence, modification to adult formulations, but non-availability of pediatric formulations. Switching to the second line could have happened late because we didn't have issue. The drugs or the patient was not ready, whatever. If the child on second line undergoes viral load testing, say every 6 months, as we know, we just talked in the previous slide, right? And his viral loads are more than 1,000 copies continuously. What do we do? When failing on second line, recommended third lines, please remember, we don't have drugs for less than 6 years, less than 10 kg. All that we need to do is emphasize on adherence and hope for the best. More than 6 years, 6 to 10 years, more than between 20 to 30, we do have DTG. We have lopinavir with the existing backbone. We can add both that. And so you have DTG with lopinavir, ritonavir, and the NRTI backbone, which could be lamivudine. Then you can have that as a third line. More than 10 years, more than 30 kgs, they could be failing on even tenofovir. Again, you have DTG and lopinavir, ritonavir plus the existing lamivudine. So these are the only options that we have. These are available in our national guidelines also. And again, monitoring is almost the same. You do the same monitoring, but again, here the timelines could be in the initial phase, monthly, 3 monthly, depending on how the child is doing. But we do need to do viral loads at least 6 monthly to see what's happening. Advanced stage could have happened. Advanced stage diseases are difficult to manage because quite a few other problems do crop in, and everything affects the child's immunity, whether it's the mental health, it's the physical health, whatever, right? Thank you very much for patient listening. And if there are any questions, I will be very happy to answer them for you.
Thank you so much, ma'am, for facilitating this important sessions. Participants can put their questions in the chat box or they can unmute their mic.
And if there are no questions, or if you have it any time later, you can send it across to Shweta and I will answer them.
Certainly, ma'am. Any questions from the participants? Please feel free to unmute. Ma'am, I don't think there are any questions.
That means either I have talked and it's nobody is really both ways, I have talked very well and everybody has understood everything.
People do understand, ma'am.
No, it's a difficult topic. So I fully agree that, switching to second line and third lines. But for all of you, my one appeal, as I have been doing for years, is do not ever remember the drugs or their dosages or what will follow the second line, what will follow this drug. If this drug fails, what do I switch? How do I, anything. Just go to your charts, look them up and do it, including for your weight bands, because that is the most easy way to manage these things, because these are very difficult, situations, and they are individualized. It's not that you can give the same drug at the same, like other drugs in your thing. So do remember that it is very important not to remember anything as we used to do in our post-graduation days or the undergraduate days. Don't remember their doses. Just refer that. Only thing one needs to take back from this is how do we manage these children holistically as a whole.
Thank you, ma'am. Participants are requested to please attempt the feedback poll. There are 4 questions in all. Scroll through the questions and answer all 4 of them. Requesting all the participants to quickly attempt the feedback poll. Also, request to all the participants, we have included the ARTC code in the Zoom registration fields. So please mention your ARTC code while registering. Kiran sir, we can end the feedback poll now. Thank you so much, ma'am.
Thank you, and thank you everyone. Have a good day.
Thank you to all the participants for patient listening. Thank you. We'll conclude the session now.